that, okay, we have patients who have some sort of problems already, they're already on medication or being managed with lifestyle changes. So what they should do when the month of Ramadan come up, and whether they should fast as normal or they should consult their doctors before they start fasting. This question always comes to everyone's mind, and there are lots of ambiguities in this, and answer is not straightforward. But I have these few trials. I'm not going to go into details, but they are. So these are the couple of trials. There's not much data in the literature, by the way. So I have got few trials from British Medical Journal and European Society. So, and most of the trials are done in UK because obviously there's a lot of Muslim population in UK. A few comes from our countries as well. So this was an observational study for patients with chronic coronary syndrome, like those who have coronary artery disease, have stent putting or bypass, and they're stable. So they're going well on medications. They are not unstable patients. All reported that Ramadan fasting was not associated with increased cardiac mortality. With 29% of patients reporting improved outcomes. Okay. And there was another systematic review by Salim et al. In 2013. Ramadan fasting is not associated with any change in incidence of acute cardiac illness, and majority of cardiac patients can fast without any difficulty. Improvement in their lipid profile has been noted, 30 to 40% increment in good cholesterol levels. As reported, some studies appear promising in that. So we have seen that lipid profile, especially the good cholesterol, going up when they do fast. And nowadays there is a lot of talk about this intermittent fasting as well for weight loss. So obviously this is natural way of doing intermittent fasting. So diabetic patients, Usman will come to that. They should be very careful because we have seen problems with diabetic patients, especially with their regime, especially if they are on insulin. So I will leave that my colleague to discuss about it. So we have, sorry for this very slide. Okay. All right. So we have various categories of patients. As I said, we need to understand that who can fast, who should not fast, and who is definitely not going to fast. So there are three categories of patients. So one is moderate risk, which include like stable patients, any stable patient, high blood pressure, stable diabetes, or they have some sort of like pacemakers implanted, but they go in cardiac, but they are stable on medications. Previous bypass surgery, but stable, no angina, no symptoms, well controlled. And pulmonary hypertension patients are also their obese patients with high pressures on their right side. If they're stable, going well, not on any much medication, not taking a lot of fluid tablets, they can still fast as normal. High risk patients, they should not fast, and high risk patients are who are poorly controlled. Blood pressure poorly controlled, diabetes poorly controlled, recently had a heart attack or a bypass surgery, recently mean within less than 6 weeks. If they're more than 6 weeks and stable, they're still okay. Hypertrophy of the heart, this is a condition in which they have muscle thickness of the heart, and they can get various problems if they are dehydrated. So I'll not go into the detail, but if that condition is, if one of the patients have this condition, they should see their doctor before fasting. Severe heart failure, poorly controlled rhythm disturbances as well. And those who have defibrillator implanted, those patients who have that device which shocks them when they go into that life-threatening rhythm, so they are still considered at high risk. So they should also contact their doctor before they consider starting or get their device checked. And very high risk are those who are advanced heart failure. You can't read it, but I can read it for you. And severe pulmonary hypertension. This is a slide not only for the cardiac patients, but these are the medications. Because every patient who comes to us, the first question they have, I'm on medications, what should I do when the Ramadan? So again, the safety is first, so we have to see what medications they are on and whether we can curtail the medications to a longer acting. So if they are on 3 times a day, if we have a longer acting agent, so we give them once a day agent or twice a day, so they start with early in the morning when they fast, and then when they go. So this is something we advise them, and there in cardiology world there are many medications which are long acting, and we can always continue them to longer acting. But if you're acutely ill and if you are taking diuretics or on fluid restriction or on fluid balancing, so sometimes it can become difficult, especially in an advanced heart failure patient. So I'll stop there. I'll have you one or couple of more slides, but any questions?
You said on the first category is the patient is stable after and stands on bypass, but due to variation of the climate, temperature, in some countries temperature might be moderate or even winter time, but over here, as the temperature is going up to 40 and you have to take a lot of fluid, in that case, what is best?
Again, the same thing, that if you are tolerating, so there are few things which we have recommended to the patients when, obviously, especially summer, Ramadan in summer, the trial fasting before the month. So you see how you go, can you manage or not. So there are various studies on it as well, that you actually prepare them for fasting. Because before they had any cardiac condition or before they had a bypass, they were normal and they were doing it normal. But once they have some sort of condition, which is stable, and they are going well with that, and they still don't know how they would respond to when they go into the month of Ramadan, the trial fasting is an option as well. But again, if you cannot continue fasting without having taken some water or keeping yourself well hydrated, then obviously we have excuse on that, and Allah knows that.
I just want to comment on this. I think for diabetic and heart patients, there are a few things which they should have at home. Glucometer, blood pressure operator, weighing machine. So how I approach it, and Abdul probably the same, we're asking our patients, especially with a heart condition, to monitor your weight daily. Same time on your same scales. If your weight is going up by 2 kilograms in 2 days, that means you're retaining fluid. If it's going the opposite, that means you're losing fluid. If someone on diuretic, again, you have to think twice before you subject them to fasting, especially if it's more than 15 hours of very hot day. So probably you can reduce the dose of diuresis after having a chat with your cardiologist or your general physician. And I'll probably ask Dr. Baig to comment about being a general physician in that kind of scenario, what kind of advice he gives, because obviously we look at from specialist point of view, but from general physician's point of view, he wants to add something like that to be useful.
Yes. Okay. So especially for heart failure patients, daily weight is very important. So that's a very good indicator for.
Sorry, I'll probably ask Dr. Baig to
Yes.
comment as well. That's right.
Yeah, so with the cardiac conditions, it's probably the best is to talk to your GP, because he knows you well. He knows your cardiac conditions. He also lies with your specialist. And he also knows what medications you're on and how you actually reacted to some of the medications in the past. So he's probably best placed to help and assist and guide you. For me, we tend to get patient asking not for diabetes or cardiac condition, but heaps of other medical conditions as well. So the best thing I would recommend to patients is, or the people who they have significant conditions, to talk to their GP about a month in advance. Right? So why a month in advance? That because the medication can be adjusted, and a trial fasting, as Dr. Sheikh said, can be actually implemented, and then you can see how you go. In regard to your question, if you're saying that if the patient is got a history of cardiac conditions and otherwise he's stable, he has stent put in, he takes some medications, and a lot of the medications are now can be taken once a day or twice a day. So those days are gone, the patient were taking medication 3 times a day. Apart from sometime, your cardiac patient taking diuretic in the morning and then taking additional diuretic at lunchtime. So that's still going on. At the end of the day, the decision is your decision. And if you think you got the capacity to fast, you can give it a shot. But if you think hot weather, your conditions, your ability, It's between you and God. No one is going to judge you. If you think, oh yeah, I think I better not do it, that's okay. Perfectly fine.
Allah knows better. So obviously we have that liberty given, and then obviously there are options of compensating for it later in the older weather as well. Any more questions?
So I think that categorizing patients, heart patients in ischemia and heart failure, probably that's relevant as well. So
Yes.
probably you want some comment on the heart failure patients and which patients shouldn't be fasting from a cardiac point of view, especially if they're taking particular drugs or severity of the disease.
I got some scenarios.
Yeah, so I think that would be the best thing because we have various categories of heart failure patients. So stable heart failure patients or who are difficult, who can actually decompensate very quickly with little bit of change of fluid status, if they are difficult patients. And they should be actually encouraged not to fast because obviously there are problems with them. High dose diuretic, they're taking too much fluid tablets, they have to maintain their weight. So these are the patients who are tricky especially in hot weather when it's quite. I have one patient who came in today who just goes back home and then bounces back again because in the hot weather he keeps on drinking too much water and then he bounces back to Kalviri hospital. So and then when you ask them to restrict the fluid, it becomes difficult for them. So yes, it is. Heart failure patients are the tricky patients to manage. Stable ischemic heart disease, coronary artery disease are easy patients. They can fast most of the time without any problem. If the stable heart failure patients, they can still fast if they are not on just one diuretic a day, or if they are not on diuretic. There are very many patients who are not on diuretics. This is still very important. Smoking is also a very important risk factor, and I normally say this is the best time to stop smoking. If you don't have a craving, if you can stop in Ramadan, especially if you are not smoking straight after breaking the fast or straight before Salat, so it's the best time to stop smoking. There was a Ramadan tobacco use cessation initiative which was carried out in worldwide, but the London by Ramadan campaign reported that more than 83% of Muslims in London showed positive attitude towards smoking cessation during Ramadan. Then another study was in Pakistan that 91% of smokers who attended a smoking cessation clinic gave. A survey reported that 97% of Muslim smokers in Malaysia feel that stopping smoking during Ramadan is more straightforward than other months. So yes, this is the best time, but
But if they didn't
we
stop
have
it after the half, will they stop it now?
that's possible. You need only one an extra faith to do that. The impact, so I can summarize it. The impact of fasting during Ramadan on patients with stable cardiac disease seems minimal and does not lead to an increase in acuity. So that's the important part is stable cardiac disease. Most patients with stable disease can fast. Most of the drugs and their regimes are easily manageable. As we said, we have longer acting agents. Most of them are longer acting and once a day or twice a day. Healthy and non-pharmacological means is the best way of actually managing your risk factors there. Controlling the blood pressure, diabetic management. If you properly fast and not eating too much carbohydrate at the time of breaking fast, you can still lose weight as well. Patients with uncontrolled symptoms or conditions, hypertension, high blood pressure, acute coronary syndrome, as I said, decompensated heart failure, recent interventions, recent surgeries, recent stent, should not fast, and best month to quit smoking.
A question which is probably won't concern general public. Most of the blood thinning medications are renally excreted. In Ramadan, you are getting dehydrated, your urine output is decreased. Is there any impact on the dosage of that, or you need to modify that, or you carry on the same dose?
I think they again, we have, like if you talk about newer anticoagulants, apixaban is not completely renally excreted, it's hepatic clearance. Predexa is the one which is mostly renally excreted. And then if you are worried if they have borderline renal, you can still change. But I think I'll let Kashif answer that because he deals with them much more
So
than me.
for AF patients,
Yeah.
Pradaxa, yes, 80% will get cleared. Apixaban, there are 5 different mechanisms: liver, renal,
Should not
through the
get
skin, shouldn't have any problems. And usually you have a very good compensatory mechanism for these things. Renal perfusions get cardiac output 33% of the time going to each lead to them. So if someone have a stable renal status, they shouldn't have any issues. But if you're concerned, obviously, those are the discussions which have to happen before. And nowadays, I think the intermittent fasting is more prevalent.
Yeah.
You tell people, for example, with atrial fibrillation, come to you to lose weight. Next time when they come to you, those who listen, they started doing intermittent fasting already. The third option is Xarelto, and usually again, no significant renal dependence in terms of parents. So most of the patients, they shouldn't have any problem. And if someone have renal impairment, they shouldn't be on Pradaxa to begin with, because again, that's one of the relative contraindications.
I've got 2 questions. One is about water, and the second is intermittent fasting does not exclude water. So most of the people are drinking water. They come off their carbohydrates primarily, so they're still drinking water.
Yes.
So that doesn't really apply to our fasting.
So
But yes,
agree, but again, if someone have relatively stable renal function, LFTs, and they're tolerating these things, shouldn't be any problem. In terms of what was warfarin? Warfarin is the trouble because it interacts with a lot of things. And what you're doing during fasting, you're changing your gut biome. And we don't know much about gut biome, how they interfere and interact. Again, coming back to the comment Atul has made, at the time of iftar, try not to compensate for the whole 24 hours. So use less carb, or use those carbs who are slowly releasing energy rather than high carbohydrate index. And try to be rationalizing, you don't want too much fluid shift when you kind of having your iftar. And that
Other
always.
blood thinners we talking about ticagrelor, and they are again not really used
Yeah.
so they are very safe.
In
I think
the
Pradaxa, if I have a patient, I will change Pradaxa because that's the only which is really.
In with the warfarin, we can change the frequency of quantity. Instead of once a month, we can go fortnightly or weekly. That can easily.
no, that was the question that we need to.
If there's a concern,
Yes.
So do you want to discuss scenarios? I think
so I'll just have a quick.
Sure. So thank you, Dr. Sheikh. I would ask Dr. Sheikh to go through some of the practical scenarios we come across with his professional tenure and just we can learn from them.
So, Assalamu alaikum, brothers and sisters. Thank you for the opportunity to come and speak for the community members. My name is Zakaria Beg, and I work in northern suburb of Adelaide, it's Holston. I haven't actually prepared a fancy presentation than these 2 presenters have. So we know Ramadan is an important month for Muslims, and fasting is one of the 5 fundamental pillars in our religion. So the fasting in Ramadan improves spiritual and physical health. Some other benefits include it strengthens the believer's relationship with their prayer. So there is also a great opportunity to make some healthy lifestyle changes, as Sheikh said. So for example, you can take it as an opportunity to quit smoking, or if it's done rightly, you can also lose weight. However, we are all humans, so we come in different shapes and sizes and body. We are not the same. So our medical conditions are different, and our treatment requirements are different, and how we react to different medication is also very different. Otherwise, we would have to all be taking the same medicine we find. So the most important message today is to find yourself a GP and have a good relationship with him. Stick to him, don't change it, because changing the GP actually not in your favor. It can fragment your care, so you see one here, one another here, another one. So just find one, stick to it, and you'll be fine. So if you have any concern and need advice, he's the best person to speak to. He or she is the best person to speak to. He has the knowledge on the health. He coordinates your care with the specialist. He knows what medication you're on and how to react to those medications in the past. So the vast majority of the time, he will provide you sufficient advice that you need. Different advice based on your individual circumstances. So the advice to one individual will be different than to the other individual based on individual circumstances, what medications he's taking. So as a GP, I do categorize them into three categories based on their risk. So there's a low risk patient. So the low risk patients is like, for example, a patient who is got just diet control diabetes. He does not take any medicine. He's otherwise healthy, fit and healthy. So that's a low risk patient. So he can fast normally. And then there's a patient who has blood pressure problem, and he take medication, and his blood pressure is well controlled. Right? So he's also a low risk patient. He doesn't have any other cardiac history. Then there are some medium risk patients, so they're diabetic on oral. So for example, the patient is taking metformin and also taking glycoside. Right? Then the medium risk patient also includes some acute infection. Right? So that's medium risk patient. So let's say a woman has a UTI, right? So that's is an infection, but it's a medium risk patient. The risk being that if she do not take medicine, can go into pyelonephritis and infection get out of hand. Then you go to high risk patients, which are actually diabetic on insulin therapy with history of hypo without fasting. So that's a high risk patient. Angina patient, right? And the heart failure patient, the one they have a shortness of breath and leg swelling. Arrhythmia patient, certain arrhythmia patient, and some infections are also high risk. So someone developed, let's say, COVID infection, acute COVID infection, or someone develops pneumonia, right? So that's a high risk patient. Those probably will be not to pass. So I give you some examples. So let's say a 70 years old man with hypertension. He takes his medication such as Avapro HCT, which is a blood pressure medicine with a little diuretic. He also takes amlodipine. This patient blood pressure usually is 115/70. That's his usual blood pressure. He wants to fast. He's 70 years old. I put him on the medium risk category. Right? You might just say, okay, but he's okay otherwise. Why not in the low risk category? So the reason is that while the cardiologist might say, oh yeah, that's fantastic blood pressure, that's what we're aiming from GP perspective, from my perspective, he's at high risk. Because why? He may, with the hot weather fasting and taking a good small diuretic, he may develop what we call postural hypertension, which is blood pressure may drop a little more with the fasting, dehydration, hot weather. And then dizziness may lead to a fall, and if the dizziness may lead to a fall, he can then break his hip. Then his chances of coming back living at independent is about 50%. Right? So from what it looks like, oh yeah, it's okay. That's what we may do is to alter his medication a little. Right? So we would probably bring his blood pressure to maybe 130, 140 over 80. We might have said that's okay for this now. So these are the things that the GP can actually look into and treat. Okay, so the other patient is 75 years old with significant heart failure. He experiences shortness of breath and he gets leg swelling. He takes heavy doses of fluid tablet, diuretics, morning and lunchtime. In the past, he had heart attack and had a bypass operation. His renal function is impaired. He's also type 2 diabetes and takes metformin and Forxiga. So this is I would class him as high risk patient. Should he fast? Probably not. But then again, that's our advice. If you decide, it's one of those things when these guys, surgeons, want to put patients under anesthesia, anesthetists say, no, this and that, he's got high risk. Eventually, they want to do it, they'll go ahead.
That's what you do?
If they want to do it, they're going to do it. They'll find a way to do it. Okay. Then you got a 50 years old lady who is normally a diet controlled diabetes, has a obesity, BMI 38, she doesn't take any medications, and she doesn't have any other health issues. Her last hemoglobin was, the 6 monthly number was 6.4, right? So which is pretty good. So she intends to fast. So this patient, I would class this patient as a low risk patient. In fasting would be advantageous for this lady, so she can lose weight if she does properly, and then that her blood sugar will improve, weight will come down. Yeah, so this would be reasonably good for her. So if you're controlling your diabetes with the diet, then fasting would be beneficial. Now there's another patient, he's a 54 years old laborer. He's type 2 diabetic. Being controlled on metformin, 1 gram DV, and glycoside, 60 DV. He's otherwise, when I say DV, sorry, I mean twice a day. Right. He's otherwise fit and healthy. His diabetic control is good. His last HbA1c was 6.5. He does his physical job keeps his weight within the recommended range, and his weight is fine. His BMI 24. He intends to fast. So what is his risk? So it's a type 2 diabetes. You take metformin, glycoside. I put him in the moderate risk category. And why is that? Because he takes glycoside. Glycoside can cause low blood sugar. Considering he is a physical worker, when he fasts, he's just going to work the normal way he's working. That can drop his sugar, and that can cause hypo. So I would class him as a moderate risk. So he might need some adjustment of medication, right? Then there is, and then some of these patients, say for example, this patient I just mentioned, 54 years old, diabetic, type 2, they can take advantage or use of those 24 hours monitoring sensor. Now they're not EPS eligible for that because they're type 2, but they can buy it. They can still use it. Right? It will keep an eye, checks their blood sugar every minute or every few seconds. So if the sugar is going down, we'll give them an alarm. We'll let them know the sugar is going down. So it's very useful for people fasting. It costs them about $200 for a fortnight, but it's a very useful thing. Particularly if they want to do it, use it will come down and there's a risk of hypo. Right? So that can be utilized.
$400 per month.
$400 per month. But some of your statin cost more.
I think that the older devices are actually a little cheaper.
Yeah.
$200, and the sensor is $400 for some of the older devices.
It's actually quite useful now. Regardless of the fasting, we are recommending sometimes this sensor to type 2 diabetes because it gives them a very good understanding what they eat, what happens to the blood sugar, and they get surprised. Right? They say, oh, we only had 2 rotis, and then they see the blood pressure spike to 16 or 18. Right? So it helps them understand what to eat, what not to eat. Even if they use it, it could be used as a diabetic education too. So use them for a month or 2. We'll tell them what to do, how to manage, what not to eat, and then they're okay. All right, so then we've got type 1 diabetic patient, 38 years old. He takes insulin, both long-acting and short-acting. His diabetes is not well controlled. His last HbA1c was 9. His random DSL is 40. he sometimes gets hypos. He's asking if he can fast. So this patient would be classed as a high risk patient. So I wouldn't probably advise him to do it. But if you really insist, then we can negotiate. Otherwise, then there are some acute problems. Say, so these were some of the chronic diseases. So I'm not actually limiting risk to just diabetes and cardiovascular. So we got a 34 years old man who hurt his back 2 days ago while lifting something heavy at work. CT scan showed he's got a disc bulge. He's at work. He's on work. He's prescribed pain medication that he takes 3 times a day. He's given a week off from work. He wants to fast. Takes medicine 3 times a day. So these will be classed as a low risk patient. There's no life-threatening thing at a risk to him. So yes, his pain medication can be reviewed and we can change it to twice a day. So that he can fast. And we got 28 years old with fever, sore throat, cough, runny nose. His rat test is positive. So he's got a COVID infection. Should he fast? Probably not. Then we got a woman diagnosed with urinary tract infection, prescribed Caps 4 times a day. You know, that's a low risk and more moderate risk. You can easily change that medicine to something, you know, you only have to take once a day, for example. So that can be managed. So a lot of the medications these days can be tweaked and can be alternative can be found that you can only take once or twice a day. Be aware of sometimes you're taking antibiotic, they have side effects such as nausea, diarrhea, and so be aware of those. So my general advice is if fasting makes your medical condition, then don't fast. If skipping medication will hurt you, then take medicine. Self-inflicted suffering is not expected here. Right? If someone is unable to fast, they don't have to. Right? There are alternative provision available in Islam. Thank you.
If there's a patient, as in talking about the risk categorization, if there's a patient who have had or have ages ago in the recent or in the past has had a gastric bypass, their absorption is impaired, their capacity in the stomach is impaired. Do they have to do any changes, or do you do any changes to them to make them fast, or can they fast?
They can fast. They probably have to focus more on their fluid intake than the food intake, right? So the fluid intake, they will make sure they have adequate fluid intake in the morning and with that as well. They can also be, if they come and see us in advance, we can ask them to do a trial fasting and see how you go.
My question is, people who work on 24-hour operations have a different shifts, and sleeping pattern are different, and especially during Ramadan, you're going to have a food one and 12 hours once. And you're going to open it at our time, and also you're going to have a food when you're going to in the morning. On that case, what is the best time for them? Because the risk of they have a lot of carbohydrates and protein as well. What is the best time for them to other they take when they are busy night take it during after fast, or take in the morning when they have start eating as well?
So this is my preference. So my suggestion would be when they break the fast, right? They drink 24 and consume less food at that time. So not like food and water together dumped it in the stomach.
Yes.
So you have maybe a date or just say some sort of drink, and then just drink, a liter and a half of water or something, and let that get absorbed into the system, and then go out and eat something. So that will improve their hydration, right? And then they can, eat, and then in the morning they can have a good meal.
But then there will be so much gap, 24/7, 24-hour gap between food. Metformin, I'm talking about extended metformin. If he has taken in the morning, then not able to sleep, it's better he take when he breaking fast, so that the night will be active night, and then daytime he will sleep.
So the metformin that he in extended release, that can be taken twice a day. So he can take it with the iftar,
Yeah.
and we can also take it with suhoor. So that's okay.
Then you can reduce the dose, say if you're taking 1 gram, take 500 in the morning, 500.
We'll probably ask Dr. Mushtaq to be
And
economic
also
for his
the
comments.
metformin, the one good thing about metformin is it doesn't actually drop your blood sugar. Right? So keep that in mind. So it's not like you're taking 1 gram, then reduce it to half a gram. It's not necessary. It won't, your fasting will not drop your sugar. So that's an important thing to know. Okay. So the other thing, sometime, for example, type 1 diabetic, and they're on insulin, right? So when the Ramadan comes, then they say, okay, well, I'll fast, but I'll not actually take insulin. So they should not do that, because what they can do, they can go into diabetic ketoacidosis. That is a very critical condition, because not taking insulin at all. So they should talk to the doctor and have a consultation. Maybe their insulin can be reduced, or something else. Thank you.
Thank you. Dr. Mushtaq, I will ask him to come and present to us Ramadan and diabetes. As I've already mentioned, he's a colleague and a senior endocrinologist currently working for Elizabeth and Royal Adelaide. Actually, he's on a long leave because he's looking after his couple of little ones and so on. So we'll ask him some tricks of his trades about better management of patients with diabetes in Ramadan. Thank you.
Thank you, Rashid, and thank you for giving me an opportunity to come here and talk to you. For me as well, it gives me a reason basically a lot talking to you guys. I don't have many slides. I think I'll keep it more interactive. And before I go there, I want to ask you don't have to answer. How many of you guys have or a family member close to you or a household who has heart problems? And how many of you guys who have diabetes or a close family member or a person in the household has diabetes? So most of the people does have a family member or they have diabetes or heart problems. That is becoming very prevalent. Said about 500 million people in the world at the moment are diabetic, and in countries like Pakistan, India, Bangladesh, the prevalence is much higher, of 1 to 2% when it comes to the first 5 countries who have diabetes, high proportion of diabetes. So, as Dr. Baig mentioned, that the education is the most important part when you prepare yourself for fasting if you have a diabetes or heart condition. If you're going to play a sports match or something, you have to do some practice. So it's the same way, the fasting, a month of Ramadan, all wait for the entire year. And many reasons, physical fitness as well. I always look forward to lose 2-3 kilograms of weight or get healthy as well, change my eating habits as well. It's not a month of overeating, which that's what we should remember, that it's a month of less eating, focus on the diet as well as your eating your eggs in a way to repeat Allah subhanahu wa ta'ala. So it's important you speak to your general practitioner about a month before talk about your medication, you talk about your risk. There are tools which are available for the physicians or general practitioners to stratify your individual risk. Are you supposed to fast, or you can, if you're advised not to fast, it's absolutely right. That's one of an opportunity or given this luxury, whether you're not able to fast, then you should not fast. There are high-risk categories as we discussed. One of them is type 1 diabetics is high-risk categories. The ones pregnant females are high-risk categories. People who have multiple comorbidities, they are high risk. So these should avoid fasting. And then they should be aware of the symptoms of hypoglycemia, because the low sugars can kill you more quickly than the high sugars. So you should be aware of the hypoglycemia symptoms. How frequently you should be doing the blood glucose monitoring, that's important. How would you be administering your insulin, what doses, how you need to change, and what are the safe glucose targets are during the month of Ramadan. So these are all part of an education. That's all the part of the practice you need to do before you go into the month of Ramadan. The main risk what we are worried about people who is fasting is hypoglycemia, means low blood sugar levels. Hyperglycemia is equally important. We don't want the diabetes. This is not a month where you should forget about your diabetes control. We should still look after our diabetes and make sure our glycemic control remains optimal. And the dehydration risk, when you're now, particularly now in Australia, it's going to be very hot weather. The risk of dehydration is there, and if you're dehydrated, risk of blood clots increases as well. So how are we going to manage that? And the key question is going to be extreme conditions, particularly type 1 diabetics and more quick. And there are certain type 2 diabetes medications and heart failure medications these days which they have a risk of going into ketoacidosis if they're fasting. So diet is an important part. You should not increase your overall diet in the month of Ramadan. You should use the more low glycemic index foods, avoid refined sugars, avoid saturated fats, avoid excessive exercise or carbohydrate intake, keep yourself hydrated, and avoid overeating. Now, I think the more important thing is people who are diabetic is what then is that how are they going to manage with diabetes medications. There are now cocktail of medications available for the diabetes, and it's not just limited to medication. There are different types of insulins as well, which you need to speak to your general practitioner how you can change it. There are most of the medications you can use during fasting months, as previously Dr. Coker mentioned. The intermittent fasting has become quite common in the view of people who want to lose weight and become more fit. So the similar advice we give to them as well. So it's important. So during this, I'll just quickly go through some of the medications, and then we can have, if you have a question, please ask me. Metformin is the first line agent for the diabetes that's used worldwide. Everyone who starts with diabetic will have metformin unless they're not able to tolerate it. It does not reduce your blood, it does not cause hypoglycemia. So the way it works is not that it's going to produce more insulin in your body, it is to reduce, it improves the sensitivity of the insulin, so it does not cause hypoglycemia. Most people who are just on metformin can continue to take metformin, particularly if it's a slow release, as you mentioned, XR dose, they can continue. Now you can take XR in a single dose, or you can split the doses twice a day as well. In month of Ramadan, I would suggest better is to take when it's your biggest meal. If your iftar, after the iftar is going to be the biggest meal, then just take metformin at that time. If you're supposed to take one tablet in the morning, one at night time, you can take one in the morning, or both of them at the iftar. Or if you want to continue taking one in the morning and one night time, which is absolutely fine as well. It does, when we start using more tablets together, then all of them does become a risk of hypoglycemia. Still, the metformin is probably the safest drug. Sulfonylureas and the insulin is the more culprit. That's what we are more worried about. Sulfonylureas is triglycerides, diabetes, these are the risk of hypoglycemia. That's what we should be educating before we start fasting and how we're going to change them. The reason is what these type of drugs cause is the X is to increase the production of the insulin in the body. So we should be using as a slow release one more of the neoclassic glycoside glycoside. It should be used when we open the fast in the evening rather than when we fast in the morning. They usually are once daily dose anyway. And if you have an opportunity to discuss, for example, your type 2 diabetic, you're on a 2 medication, metformin and glycoside, then you can discuss with GP whether you should change to another type of drug. Now, sulfonylureas in the older class, it's not the preferred drug these days. We have a lot of other medications we can use safely in anyone, not just in diabetes or not just in Ramadan. So it can be easily switched. Problem comes in when they are on 4 or 5 medications, they don't have anything more, and you have to take sulfonylureas, then you can just adjust the dose. Now, DPP4 inhibitors are, again, this is a drug of what we call as gliptins. So again, there is no risk of hypoglycemia. They can be used as they are in a single dose, twice a day dose without risk of hypoglycemia. They normally don't really affect much. GLP-1 analog is the one we're using more these days. It's a once weekly injection. They are not insulin. They are medications which works through various different ways. I don't know how many of you have experienced this. We are using this a lot in weight loss as well as non-diabetics. And the usual advice is to continue as it is. There's no need to change. Now, SGLT2 inhibitors is a lot of concern about these medications. So these are the ones which cause the glucose to be secreted in urine, and for that it needs to get rid of the fluid from the body as well. And the risk of dehydration, the risk of ketoacidosis is high in this people who are taking this group of medication. And this medication has been used in most of the cardiac patients as well. If you have a heart failure, they can be used without being diabetic. They use multi-purpose drugs. And there's a lot of questions being asked when they should be taken. Normally we advise them not to take it if they're going for a surgical procedure. If they're going for a surgery, we're not talking about Ramadan or fasting at the moment, fasting in Ramadan. If they are going for a surgical procedure, we ask them to stop it taking 3 days before the surgery. The Ramadan fasting is different from the fasting they do for the surgery. So you can still take the medication. All you need to make sure you're hydrated enough, keep yourself hydrated before you start the fasting. And ideally should take it in the evening rather than when you're opening up the fasting rather than in the morning. That's the best time it is. The risk of ketoacidosis is actually small in patients who are not diabetic and the heart failure patients. So it's pretty much okay for them to have a daily have to discuss if there are 3 diuretics, 2 different diuretics, and they're using this, then maybe time to think about if they want to do something differently. The insulin, we have different varieties of insulin, long-acting, short-acting, the mixed insulin as well. The advice for a type 1 diabetic generally is want fasting, in particular if your diabetes is not very well controlled, if your HbA1c is more than 7.5% or you're getting frequent hypoglycemia, then you should be more fasting. Now there's a lot of type 2 diabetics who are just on insulin and they're not on medication. They're being treated as type 1 diabetic, being on insulin. They, again, if they have a lot of risk factors, as Dr. When has mentioned, if you're high risk category, then the advice to them is do not fast. But on the other side, if you're just doing long acting insulin, if you're taking once daily insulin, if you're taking in the evening, just take it with your start and it should not be a problem. If you're taking the long acting twice a day, then take a bit more dose in the evening and about 30 to 50% less dose with the you're doing the sugar. And shorter acting is short acting insulin like lower rapid act rapid should not be taken on when you're fasting. You should take about 50% less dose when you're doing your sugar, and take a little bit an extra, or depending on how much meal you're going to take, an extra when you open up the fast. The pre-mixed insulins again, they have a combination of a short acting and longer acting, or sometimes intermediate acting. Take a 50% less insulin dose with the sugar, and you take a little bit extra, or 10-15% with again, depending upon if you're not really having a very high carbohydrate diet with the FDAR and looking after diet, but you don't use that carbohydrate, use the dose very easily. If your overall 24-hour meal calorie requirement is less in the FDAR, you can just take low, and it's low instead. Dr. Irfan Bhai asked me a question earlier about the insulin pumps, which I haven't mentioned. The insulin pumps have been used in many type 1 diabetics, in particular in Australia, the type 1 diabetics are eligible to have insulin pumps. What do we do with them? Look, again, the type 1 again has risk stratification involved. If you can, if your health practitioner tells you don't fast, and don't fast, but if you really have to fast, you do increase. There's a rate of insulin which is given to you by the pump 24 hours a day. You increase the rate when you're opening up your fast, and you reduce the rate when you start fasting. And the blood glucose monitors these days are very helpful. So they will be automatically, if you're going into hypoglycemia, they will notify you. And again, I mean, I know the cost is an issue, but again, if you really want to fast during the month of Ramadan, I think $200-300 cost for that month is not that high cost. You can use that if you're worried about hypoglycemia and hyperglycemia. So I think overall the message is many people with the type 2 diabetes can fast, but you still need to speak to your GP, prepare yourself before Ramadan, practice beforehand, and the right diet, the right choice of medication. They most are able to fast without any problem. Questions?
My question is especially Pakistan, when we break fast, we just
Break everything.
break everything. And samosa, pakoras, all sugary things. Then, and then, it's this, we are not with this kind of control. Then we take this, and we also just after taking, we were looking for the next attack on food. After the breaking fast, how much gap you think, because your glucose go on a shoot, when you put it on sugary carbohydrates, those GI food, how much is the gap should be as the person with diabetes to have a next meal after the breaking fast?
We usually recommend them, so it depends again on how long is your day, how much time you're going to get between your iftar and so forth. In many countries, when the days are long, you're opening up the fast.
We're talking about long.
Yeah. So here we probably going to open fast just as though it was long. So we still have long. So I would recommend that take another small snack before they go to bed. Open your fast and then have a small snack around 9 o'clock or something. And
Not heavy meal. Not heavy meal.
not having it. Not having it. Again, the idea is not to increase your calorie intake.
Yes.
The idea is to actually reduce the calorie intake. In diabetics, you're worried about you should not reduce too much. So they should have a small snack or small meal, you can say a cup of tea, sandwich or something you want to take before they go to bed, or large coffee. Now you have to go for Tarawih as well, so you might be coming back late, so have it once you come back to Tarawih, or from Tarawih you can eat small things before you get to bed, and importantly you should not miss suhoor. So you need to wake up in the morning, eat. many people say, oh, we cannot go 2 o'clock, or watch this cricket match. Now let's start eating now, and I'll wake up and do the fajr at 7 o'clock, and that's fine, that's my, I've done the morning meal. So that's important messages. I mean, it should not be for anyone, it's not just even diabetic, we have to wake up, everyone should wake up, and then I think diabetics need to eat enough of that, take glucose, remain in the body until
Is if I mean, more than kind of when you have a fast, what is the preference? We have a water first, then food, or we have a food first, then water. I mean,
it doesn't really matter. So you're not gonna have a 30-minute scan or something. So when you open up, you're gonna be feeling hungry, you're gonna be feeling very good. So have your water first. That's normally recommended. Have your water. Have a day. So again, the days we should not be eating a lot if you're diabetic. There is a very high glycemic index. For 1 or 2 days, as the disease purpose and the nutritional benefits is fine. And you still need some carbohydrate, but you should not be a handful of days. You should be eating after. So have your drink first and then start eating straight away.
I have a question. It's mother, so probably an example for other. She is a type 2 diabetes and she takes insulin twice a day. And it's very difficult to convince her not to fast. And she sometimes, like, she says during fasting, she gets thirst, like, mouth dry, like, so what is your suggestion for her?
No, look, absolutely. So Ramadan is so close to our heart that all of us wait for the whole year. Then we fast. It's very difficult to convince somebody that has been in habit of fasting the entire life and say that you fast. And particularly as you already get more and more close to your religion as well. So like the idea is, so the first of all, the thirst is it why is the thirst? Is it due to the sugars being low or high at that time, or just because you don't have enough water? So we recommend that in the morning, you need to drink enough water. Obviously, you can't drink water when you're fasting, because it will break the fast. So they need to drink enough water. Take a little bit less insulin. If they're eating less, many people don't like eating in the morning. I don't feel like when I wake up in the morning, I just do it for the purpose of things like eating. I don't tend to take every meal, and this is just how I am. And many people don't like to eat a lot in the morning. So then take significantly reduce your morning insulin, and then take more when you're eating more after opening of the fast.
You mentioned about the device that monitor that. Is it available in Pakistan?
I'm not too sure if it's available in Pakistan. I think it should be.
I think it's coming. Abbott has projected it.
So what's the name of that?
It's like
Libre is a few brands have come in. Libre was the first one who brought it in. It's Abbott's product, and it's easy, very easily used. It's very easy.
So it's invasive, like just
So there's a small sensor which has a very tiny needle, less than a needle of an insulin. It just gets stuck on the arm or an abdomen, which monitors your glucose. You have a small machine like a glucometer, and you just bring it close to you and tell you what you should do. There's a lag about about a minute or something if what you're actually having the sugars, but that's okay. People learn what the sugar is going to be, and it's a good device. It's expensive, as Dr. Dave mentioned. But again, if you're fasting for 1 month, I think $300 is not a big cost.
I would just like to comment on the device. If patients are registered with the NDSS, they might be eligible for the subsidy on that device as well. So that's a thing that maybe.
That's only if they got type 1 diabetes.
No, I think there's a DBA, and maybe I'm not too sure about the NPI especially. DBA is now eligible. Gold card holder is eligible for Medicare related, and as insulin pumps as well. So it may become regulated in the next year or 2 years for the people who have difficult to type diabetes. But I don't think so they will. And it's expensive device. I don't think so. They will allow.
I think it's co-subsidy. I think it's co-subsidy.
Yeah.
And it's called the freestyle differential. Freestyle LIBRE.
Okay.
Yeah.
One other general question, like, is there any relation between the diabetes and exercise? Like, some people say when we do some walk or something, does it reduce the insulin level or something like that?
So exercise is beneficial, and if you're doing some walking, you should do it not during when you're fasting.
Yeah,
you
not
do your
fasting, yeah.
usual activities, maybe do it in the evening. So it's beneficial. It does reduce your. So what it does, the exercise is using your energy. So using the glucose. So it is lowering your blood glucose levels. It's helping you to reduce weight, and when you reduce weight, your insulin sensitivity increases. That exercise is good. So they should not. Somebody who's fasting should not go to the gym during the fasting. They should not go to the gym and spend 2 hours a day. It's not recommended. But after that, you can do some gentle walk. You can still do we've got a group of friends who play badminton sometimes on the weekend. After around 9, after they finish the karate, they go and play badminton. First strenuous exercise for about an hour or two. That's fine.
I think there's few things now coming up. The fast, like just before you break the fast, so the best time to exercise is just half an hour, 45 minutes before you break the fast. That's the best time. So obviously not for the older people, but who like doing exercise. Either late, because nowadays the Ravi time is too late and everything, then it becomes too difficult and then you have to wake up for work. Best time is before you break the fast. Last hour.
The other important thing is checking your sugar level doesn't break your fast. There are a few misconceptions
Yes.
here that
And
you're using your
insulin does not take.
insulin doesn't. Intramuscular injection doesn't break your fast either. So please be wary of that, because these are very common misconceptions in the community. Oh, I'm going to check your sugar level. And for your mom, probably checking sugar level is not a bad idea. If she's feeling that thirst, or without even, just if she wants to fast, just check the sugar levels. And as Dr. Mashak has mentioned, you can reduce the insulin dosage by 20-30%, and that potentially will help. And she
It's
will be
very
happy.
difficult to convince them, like,
Understand.
that.
I think take-home message is the device is the best thing for the diabetic patient.
And I can like
You can
to
afford, that's the very good thing.
I like to
We can't change somebody. We should make provisions around that. How are you gonna use the same as the safety? So we can't change. We don't have to fight with them. Or you know, just say.
There are some
Just
other
work
religious
around-
things.
Yeah,
you
work
can't,
around the strategy.
If you ask them, like,
You can't
okay,
force
take
them.
it blood, like, or insulin testing is like, it's okay. And
I think this is a good thing.
yeah, that's the thing you can test.
I think the beauty about the CGM is that as a son of a mother, if she's using that device, can send you the information of that sugar level as well to 4 family members or even the doctors through that Bluetooth connectivity or internet connectivity. So that's the thing
So
which
you can buy from here and send it to Pakistan.
obviously.
Yeah, you can buy it. You can buy anyone can buy.
The Abbott's freestyle effect.
Yep.
The Abbott only sell it online.
Yes, that's easily.
On the website. It's not through the chemist. But you can buy and send it.
Go there, fine, we will give you subsidized price.
And another important thing to mention, obviously we all know this, but fasting, yes, is very important in the Ramadan. But look, we other ways to enhance your spirituality. Focus on Quran, be more vigilant about your namaz, be good to others, charity. And with that, human appeal comes in my mind. So I just want you guys to give them a big round of applause, especially to Brother Ali. For their guidance, for their support, what you're munching on, that's also by them. So we are very grateful. We're very grateful. And they also offer that if you have a CPD or any meeting like that, 50, 60 people, over the weekend, they're very happy to cater that. So thank you. Thank you once again. In the month of Ramadan, obviously we're going to be more charitable. So please, we know that Human Appeal is doing a fantastic job. So please keep that in mind, inshallah. Any other questions? Please.
First of all, I would be very thankful for all the presenters who present such a nice information, I think it's a very useful to everyone. So I have one suggestion in my mind, because a lot of information, today we discussed mainly 2 diseases like cardiac disease, diabetes type 1 and type 2. and all the medicine which is used for these needed to treat it, in the relationship with the fasting, but not much data is available, little data Dr. Rauf presented. So it would be appropriate and good, but also I think he's the public health, if something can be done with his expertise or from his department to develop some project for master PhD thesis, to have a real-time data, by considering all the issues. So that could be a first step, as far as data is concerned.
So thank you. There is data available because we were talking about more community talks to happen. My presenters have presented those data, especially with diabetes. If you are interested in data, there's a fourfold increase in sugar levels sometimes with fasting because we eat too much. On average, if someone properly performing fasting, they lose more than 1 kilo after 30 days. People who have hypoglycemia within 3 months, they are suggested not to fast. So there is data available, and I welcome your suggestion. We definitely can talk
Maximum data is available in diabetic patients, and the data has actually shown that they do worse during fasting, unfortunately.
Because they eat more.
They eat more, their diabetic controls get worse, and they do get hypoglycemias as well if their diabetic control is not good. For the diabetes, there is a lot of data available because there is a lot of research done on that. Overall, for cardiac patients, the data is limited, but it is still available. Yes, it is limited. Because the cardiac patients, most of the cardiac patients have got
Multiple organs involvement. Someone have a stage 3 kidney disease or above, we should be fasting. So I think again, this is just a generalized advice. The disclaimer here is it's generalized advice. If you need customized advice, please go to your general physician or general practitioner, and he can refer you to the appropriate personnel for further advice. But start thinking about it. For example, I will share some data in December 2031 or 2031 year. We have 2 Ramadan. That's how the group goes. So Ramadan come every year. So from today, take it as a first step, and please go back, talk to your general practitioner, general physicians. That I want to do fasting, and this is what my problems are. How can I start? And maybe you can start for a few days this Ramadan and improve to the next Ramadan, and so on and so forth. Any other questions? You're very welcome. Please.
It's not a question. It's just
Sorry,
a suggestion.
Sorry.
Yeah, so it's not a question. It's just a suggestion.
Sure.
It's good to see. Alhamdulillah, we have some good specialists. Yeah. Can we initiate, or maybe there is? Excuse me if I don't know. Can we have some kind of a pamphlet or something for our community here regarding the things that we discuss here? Because there is not like a broader population. Some pamphlets or something which have these kind of main things that okay, these are the do's, these are the don'ts kind of thing, these things we can share in Pakistan, in local villages, it will be some kind of a sadqa jariyah,
I understand, but the problem here is this is a generalized advice. This is not customized. So I can't really tell the same advice to a person who is in a village with some kind of disease which I don't know about. So that's the difficulty of the situation. But yes, about the generalized advice like taking insulin doesn't break your fast, checking sugar levels doesn't break your fast, having an intramuscular injection doesn't break your fast, go see your doctor early if you want to fast, etc. Yes, definitely we can do something about it. And this, I think today's evening has been recorded as well with the collaboration of Brother A and Human Appeal. So hopefully we can dissipate and distribute, and this can be a subject. Yes.
Sorry to say it was in English. Difficult.
Yeah, I understand that, but again, you have to be all inclusive. You have to be all inclusive.
Your question. So I think it's medical legally is very safe for medical professionals to publish something and give for a general advice. It's not possible. It can easily get sued, although the intentions might be good, which is always good intention. So we have to, there's a lot of things, ethical and medical. And again, when we're giving something a medical advice, it should be individual. And that's why we always say that go to your general practitioner. He's the one you should have a good relationship. Prepare yourself with them.
I was thinking about Pakistan. Here it is working. It's easy. Pakistan,
clinical practice becomes very down. So, and there are many reasons for it. It's not the doctors are bad. It's because of the population is. Sometimes you have to give them, like the vaccination for the COVID. They did mass vaccination every month because the danger was too high. Again, in Pakistan, there's a lot of generalized advice given because the population. Question going back to you about that question. I think it's a very good idea. So most of the literature and the data less in Australia, more UK and USA and Canada and Pakistan. Because they've done a lot of research in Pakistan and India as well because a lot of Muslims are there. So it's not a bad idea. If the medical student wants to tie up with somebody, do some research. It's a good project. It's easily publishable. There's the Australian Diabetes Society or Society of Australia, which has the guidelines on Ramadan and fasting, so you can access that online as well. So people know about the importance, non-Muslims know about the importance, and they respect that. So I think your idea is good as well, and I think your idea is good as well. I think taking someone locally, taking someone takes initiative locally would be more effective.
Thank you.
I'd like to add one more thing. It's basically, as he said, that individualized advice is important because it does not matter we are in Australia, Pakistan, whichever part of the world we are. Basic thing is when you know you have some sort of medical issue which you think fasting would be a challenge or might be difficult. So you prepare for it in advance. Alhamdulillah, everyone's intention is we all want to fast, we want to take maximum reward in this month. And like your mom, obviously she wants to fast. So the best advice, wherever it is, they should prepare for it in advance. A month before or 2 months before, see the doctor, rationalize their medications according to that. And whoever their local doctor is, even in villages, they must have their some local doctor who they go and whoever is giving them medications for their disease. So lots of things can be tweaked in a sense, like you said, that we can obviously adjust the dosing for the insulin, we can adjust the dosing for that. If they're taking blood pressure medication twice a day, we can always change it to once a day. Blood thinners, all these things, if they're renally clear, we can change it to non-renally clear. So these can be done a month in advance, 2 months in advance, and the trial fasting thing. So yes, we can make it easier and safer for them if they actually prepare in advance rather than actually on the day of fasting thinking, oh, okay, I can fast or not. So that would be very helpful anywhere in the world. And Alhamdulillah, he's right that our population, of Muslim population, is increasing in Australia. There's no Australian data. And this is going to be a very good project for Australian new PhD students there. So it's good.
Yeah, and one other just a comment that you started with the so I think the doctor is the best person to explain this to the patients, like that okay, like it's very clear, like Allah made it very clear. If you are ill, just like skip it, or you pay for that money, or like later when you become like
He has
so
made it
it's
sound very simple for us, and he wants it to, like there is no hardship in Islam.
yeah, it is. Yeah, so like being a doctor, like it's like kind of responsibility to convey this message to the patient, like because some of the hardcore religious people made it very strong, like so the doctor, like you know the better, like and you just
Mostly in
convey this
Pakistan,
message.
especially in villages, the problem is our masjid imam. So they think that whatever is coming from them is 100% correct.
Yeah.
And that is a little bit of problem there. So obviously they're not coming from religious scholars.
Yeah. Thank
Any
you.
other questions, comments? Well, please take this opportunity to read about your particular condition, or if someone in the family have a particular condition in Ramadan. There is literature available, and obviously if you have a background knowledge, you can go back to your GP or the specialist and ask appropriate questions and help them to fast and also improve this spirituality during this month, inshallah. Now, Brother Ali has asked us to say, because he wants all of us to be on TV. Is that the plan, Brother Ali?
Yes, this is going to be part of Ramadan free as well. So you're going to be on TV.
Okay.
So inshallah, mingle when the event finishes out. Do stay mingle because we might come to you and talk to you as well. So it'd be good to get your feedback about the event as well. Because this is something that, alhamdulillah, you guys all benefit, I benefit from it. It'd be amazing to share that across to the community so they can benefit from it as well.
Yeah, that would be good.
Inshallah. Jazakallah khair.
Yeah, jazakallah
So
khair.
that finishes, don't run away. Stay mingle and come to your door, inshallah.
Jazakallah khair.
Sorry, any other questions? No?
I just wanted to wonder if some videos, here people recommend we can apart from our own community, because not every you can see how is the big Muslim community in Pakistan, how many people are coming. So we have some recommended video which we can share, and also we have a connection in Pakistan. We can have some video within our language, or the language. We can send because when we send something from here, they more believe as compared to
More sacred, yes.
from Australia. Yes, they are coming from a authentic sources, and when somebody says same things in Pakistan, they just mentioned they believe more on Imam than the Quran and the Sunnah. That's the thing. That's how we can. It's all about education. More we education give, more we give them the power, more is the chance we reduce something about people here, and that's the same things we can do.
I couldn't agree more. Definitely education will empower them. And I think it's a fantastic idea. So I'll probably ask Brother Usman and Brother Sheikh as well. While our king of media is here, we can make a small video and we can propagate it from there rather than waiting and show the language.
That's what is a nice opportunity here. We can Pakistan has I think it's the highest population wise. Pakistan is the highest population wise, the highest diabetic country.
That's right. So any other, please?
I don't have a question. I have to ask something. Sorry, I do not have a question. I have to ask something from Dr. Room. Just because I am taking a lot of medication, I don't know how many medications from here are for blood pressure.
The two medications, actually three medications for your blood. Yes. So what do you want to know about it?
Oh, because whenever I travel, they ask to get the travel insurance, and they ask me that how many medications from blood pressure.
Three
And-
medications.
Living a customized care, right? So I'll just quickly summarize the medication before we finish, and you guys can keep on munching on the snacks. Metformin, try once a day, as Dr. Mishta and Dr. Baig has mentioned. If someone is metformin, extended release once a day. Go with your main meal, like a safar. Sulfonylureas, the glyphosate, etc., those has to be reduced because they are high risk of having low sugar. So again, discuss with your general practitioner and your diabetic specialist. GLP analogs, these Ozempic injections, they are very kind of popular nowadays. If someone is using it for weight loss, fasting is good enough, so you can come off those. If someone is using for diabetes, please continue with that. SGLT2 inhibitors, again, they have a diuretic effect. So again, have a chat with your general practitioner. If you have to take it with your iftar and drink a lot of water as well, because that's less chance of dehydration. When fasting goes more than 15 hours in a hot weather, then obviously the chance of dehydration goes higher. So yes, you can try a bit of fasting on day 1 or 2 and then see how you feel. Please monitor your sugar levels if you have diabetic and monitor your weight if you have heart condition and speak with you. My suggestion again will be, as Dr. Mushtaq agrees, just again speak to your general practitioner and diabetic specialist because those have to be adjusted according to your main meal. And carbohydrate count, some of us do that carbohydrate easier if you're doing it to regulate your insulin dose. If someone is on diuretics, that means the pill makes you pee more, you pass more water. Please be very, on a hot day, be fasting for longer hours because dehydration is a real concern. And as Dr. Vegas mentioned, it leads to significant issues of dropping your blood pressure when you're standing up, especially in Tarawih. And it's not unusual. We do see it once every year. Someone's collapsing while they are praying because they have a very heavy iftar, mashallah, and they just go straight and standing and they pass out because again the brain getting less fluid and the shift happens towards the feet.
Especially if you read 8 Tarawih in this. Madana.
So with this, if you guys have no questions or comments, I would like to conclude the evening. Again, I want to express special thanks to the organizing committee, to Brother Ali Jamil, to the Sisters Association, thank you, and also to Pamasa, Pasa, and IMA, also to all my presenters, panelists, and especially to you guys. It's a hot day. Thank you for being here, and I find that this evening is useful, and hopefully we can help our families, friends, and there are a couple of very good suggestions, and we'll act on that as soon as possible.
Sorry, I just wanted to say, on behalf of Alexis Association and the Human Appeal, thank you so much for this amazing initiative. Thank you so much for this amazing initiative. The response from the community was so fantastic, and inshallah we can facilitate together some more things like this. Your help towards the community may be rewarded immensely by Allah for your contribution to the review. Also, I just wanted to make a quick mention that we wanted to thank the members of MASA for your contributions and help constantly, but specifically, just to give you guys a heads up, the furniture that you're sitting on today and the new renovations that we've been able to do in this cafe, which is a not-for-profit cafe, obviously our Human Appeal offices are at the back there, is thanks to the members' contributions of MASA. So I just wanted to thank you so much. Inshallah, when this finishes, it'll be such a beautiful space. We can continue having amazing events like this and also just benefiting and helping the local community, inshallah. So Jazakallah khair, and thank you so much. Thank you so much.
So you guys can start munching so they can come, make some videos, and we can go home inshallah after that. So thank you everyone. Have a lovely evening. And please remember all of us in your prayers. Assalamu alaikum.